Hey everyone, I'm Savannah,
And I'm Leslie.
and today we're going to talk about shock. So we're going to do a recap summary video. We just talked about hypovolemic and cardiogenic. So we're first going to start with what exactly is shock. So with all types of shock, you have a decrease in tissue perfusion.
Right. And as we know, that this is caused by changes at a cellular level, which result in an imbalance of between the supply of and the demand for oxygen and nutrients.
So now we're going to go in and talk about cardiogenic shock.
Okay, so now we're going to talk about cardiogenic shock. So cardiogenic shock is when your organs are not receiving adequate oxygenated blood because of heart failure.
So you can have a systolic or diastolic dysfunction, and the end result is going to be decreased cardiac output. So the heart has enough volume to pump, it has enough blood volume, but it's just not able to do it. So that ends up decreasing cardiac output, decreasing perfusion, and eventually leading to cell hypoxia. And we know that decreased cardiac output is the amount of blood that the heart pumps per minute. So if the heart is not able to pump and perfuse properly, you can go into MODS, which could be really fatal.
Exactly. So again, this is considered a life-threatening medical emergency. So if we do not intervene quickly, this can be fatal. So it's very, very important that we recognize this and act as quickly as possible.
All right, so now we're going to talk about the etiology of cardiogenic shock. So what are some things that could cause cardiogenic shock?
Okay, one of the things that can cause it is an MI or myocardial infarction, and that is where the heart muscle cannot pump effectively.
Another thing that can cause cardiogenic shock is pulmonary embolism. So with that, we know that the blood clot in the pulmonary arteries prevent forward flow and prevent oxygenation of blood.
Okay. And then we also have dysrhythmias. This can be, for example, VFib or ventricular fibrillation, VTAC, ventricular tachycardia, or even AFib, atrial fibrillation.
So with that, your blood is pumping, but even like with AFib, you think your heart is kind of quivering. So it's not able to perfuse the body properly. All right, so now we're going to talk about some risk factors for cardiogenic shock. So some of those include older age, a history of heart attacks or heart failure. They have coronary artery disease, atherosclerosis, obesity or diabetes, and even hypertension.
All right, so some of the complications of cardiogenic shock can include multiple organ damage and or failure. This can be to the liver, the kidney, even the brain. It can also cause coma and even death. So what does a patient in cardiogenic shock look like? How are they going to present themselves? So they can present with crushing chest pain. It can have anxiety or restlessness, shortness of breath, weakness, and even nausea.
So our typical clinical manifestations too that we could also recognize in a patient with cardiogenic shock, they might have a decreased level of consciousness, increased respiratory rate, decreased oxygen saturation, decreased capillary refill, their peripheral pulses might be weak, they might have jugular vein distension because remember it's from heart failure. They could have crackles in their lungs and a low urine output.
So here's a recap of some of the medications that are used during cardiogenic shock.
So typically they'll be started on furosemide. They might be put on norepinephrine or epinephrine, dobutamine or dopamine, nitroglycerin or sodium nitroprusside.
Okay, so now some nursing implications or interventions for cardiogenic shock. These can be, we need to assess and monitor their vital signs, maintain an IV access, pain management, and we're going to assist with intubation if ordered by the MD.
So with this patient, we're probably going to have them on a continuous EKG monitoring. We need to constantly assess their respiratory cardiac function and their perfusion. And we need to monitor their urinary output as well as do daily weights and assess their skin turgor for edema, and also just repositioning the patient to make sure we don't initiate skin breakdown.
Okay, so now that we've recapped cardiogenic shock, now we're going to talk about hypovolemic shock. So hypovolemic shock is where we have a loss of intravascular volume. This can be potentially life-threatening because if we lose greater than 15% of our volume, that's when we're going to start seeing clinical manifestations.
So hypovolemic shock can be absolute or relative. Absolute is the most common, and that's when the patient is losing fluid outside of the body. So that can be a hemorrhage if the patient has a trauma or from surgery. Relative is when the fluids are leaking inside the body. That's when you'd see third spacing, ascites. So the loss of fluid from the intravascular space reduces venous return to the heart, which in turn, like we learned with cardiogenic shock, is going to decrease your cardiac output, reducing perfusion to tissues and organs.
So, some of the risk factors for hypovolemic shock include burns, traumas, alcohol use or abuse, and dehydration.
So if the patient has some of these risk factors and they develop hypovolemic shock, it can lead to some complications. Some of those complications are acute respiratory distress syndrome, kidney injury, disseminated intravascular coagulation, also known as DIC, multiple organ dysfunction syndrome, also known as MODS, neurologic dysfunction, or even death.
All right, so now we're going to talk about clinical manifestations of hypovolemic shock. So these can be where a patient may experience weakness, anxiety, restlessness. They can have excessive vomiting, diarrhea. They can also have rectal or vaginal bleeding, and their skin may be cool, pale, or even clammy.
So with these patients, we can also pretty much expect to see an increased heart rate, an increased respiratory rate, but a decreased blood pressure. Their cardiac output is going to be decreased. They might have a decreased level of consciousness, as well as a low urinary output.
All right, so now we're going to just do a quick recap of pharmacological interventions for hypovolemic shock.
So the first one we're going to talk about is normal saline and lactated ringers. Those are typically the first line for hypovolemic shock, and these are your crystalloids. Your colloids are serum albumin and dextran.
Right. We also are going to possibly give the packed red blood cells, platelets, and even fresh frozen plasma.
All right, so now we're going to talk about some interventions that we can do as nurses for hypovolemic shock. So it's really important that we maintain 2 large bore IV access. So that's going to be a gauge greater than 18. Type and cross match, we need to make sure that we know their blood type, their RH factor in case they do need a transfusion. Monitor their vital signs as well is important, and also allow this patient frequent rest periods because they're going to physically be tired.
We're also going to administer O2 as prescribed. If we're able to, we're going to position the patient in Trendelenburg. We want to maintain our ABCs, which of course is crucial, maintaining our airway, breathing, circulation. And then we also want to control bleeding if we have someone who is hemorrhaging. Okay, so that concludes our recap of cardiogenic and hypovolemic shock.
So now that we've gone through everything, we want to make sure that the class understands what exactly cardiogenic and hypovolemic shock are. So we're going to open up the floor for questions at this time.